Bismillahirrahmanirrahim. Quote of the day. On that day you will be brought to the judgment and none of your secret will remain hidden. Al-Quran. Today the topic of presentation is Health Information System. I am Dr. Rabbia Iqbal, PGR Community Medicine, and I am presenting under the supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. Learning objectives of today's presentation is introduction, source of health information system, data source in Pakistan, uses of health information, advances in HIS and MCQs. By the end of this presentation, participant will be able to learn about the health information system. So the introduction to the health information system. Information system, it is defined as a set of component, procedure, and resources that is organized to collect, store, process, and deliver useful information product for a certain purpose. Health information system is defined as a collect, store, process, and deliver health-related information for better planning, decision-making, and execution of activities aimed to improving the health of the individual and communities. So there are two kinds of data that are used in health system. Number one is the health data, continuous monitoring of birth and death, and population data. Uh, Source of population data is census, vital registration, disease notification, hospital records, disease registers, record linkage, epidemiological surveillance, oral health record, environmental data, health personal data, population survey, and non-quantifiable information. So the population data in Pakistan collected through census, registration system, sample survey, and qualitative data. So number one is a census. Census is a systematic process of collecting, compiling, evaluating, analyzing, and publishing demographic, social, and economic data pertaining to all individuals in a country or a well-defined territory at a specific reference date. There are two types of census, de facto census and de jure census. De facto meaning enumeration of individual as of where they are found in the census, regardless of where they are normally reside. De jure meaning enumeration of individual as of where usually reside, regardless of where they are on census day. Census in Pakistan. First census in Pakistan conducted on 1951 on de jure from de facto come de jure basis. Second population census conducted on 1961 on de jure basis. Third was conducted in 1972, and fourth one is conducted on 1981, which are based on questionnaire. Fifth census conducted on 1998, and the sixth one is conducted on 2017. Census 2023, fully digital denomination, de jure enumeration method. It has three phases. First one is self-enumeration, phase one. At the first step, a user login to their account and a unique QR code is assigned to him or her. In the second stage, field enumerator will be physically visit the household and verify the QR. Second phase is tabulated phase. In this step, data will be collected electronically through the tablet, both online and the offline. And the third phase is the post-enumeration survey. The post-enumeration survey is conducted through the latest techniques, for that is computer-assisted telephonic interview for the resource management. This is the census 2017 versus population 2017 versus 2023. This is a graph showing comparison of the population growth in Pakistan 2017 versus 2023. So the advantages of de jure enumeration is are accurate distribution of permanent population, useful for development, planning and resource allocation, reduce double counting, better for calculating demographic indicator, support long-term policy planning. Disadvantages are difficult to define usual residence, risk of misreporting absentee member, complex data collection process, may not reflect a actual daily service burden, requires strong administrative monitoring. Second is the vital registration system, which is defined as it is an official government system for continuous, permanent, and compulsory record of vital events of population, including birth, death, marriages, divorce, and stillbirth. And the main purpose is to provide accurate, up-to-date demographic and health data for planning, policy, and monitoring. Functions are provide population denominator for health indicators, support maternal and child health monitoring, enable calculation of crude birth rate, death rate, fertility rate and life expectancy, supply legal documents like birth and death certificate for citizen, assist in planning and evaluation of health programs. Disadvantages and advantages are accurate data, epidemiological tracking, civil registration, and cost-effective. Whereas disadvantages are under registration, report delay, infrastructure issue, incomplete data, and low compliance. Next is the population register. Continuous record of demographic and social changes of population. Pakistan is preparing a universal complete population register since 1998 by NADRA, National Database and Regular Authority, register after 18 year, multiple feeders and user agencies. So the objective of NADRA are citizen registration, issue CNIC, smart IDs, and maintain population database, identify verification, support government, law enforcement, and private sector services, data security and integrity, protect personal information, prevent identity fraud, service facilitation, population management, provide vital statistics for planning, elections, and policy making, international cooperation, support overseas Pakistanis cross-border verification. So the disadvantages and disadvantages of NADRA are advantages are centralized and accurate population data, real-time update for birth, death, and migration, facilitates for policy and planning across sector, support emergency response and disaster planning, decrease corruption, terrorist, narcotics, and illegal immigration. Limitations are coverage gap is in the remote areas or marginalized communities, data privacy and security concern. Not all health events, for example, home birth, stillbirth may be registered immediately. Integration provisional health information system is still ongoing. Third is the sample survey done to check the accuracy of the census and vital registration system conducted by the government agencies include Pakistan Demographic Survey, birth includes birth stats, estimate current rate of increase and characteristic of population. Second is the National Health Survey of Pakistan, which include morbidity pattern, smoking, nutrition, hygiene, risk group, urea creatinine, NCDs, vision, socioeconomic and occupation profile. Third is the Pakistan Integrated Household Survey, which include family size, fertility rate, utilization of health services, education, water, and sanitation. Number four is the Household Integrated Economic Survey, which include household size and savings. Next is the Multiple Indicator Cluster Survey of Pakistan, which include education, water, nutrition, ARI, diarrhea, breastfeeding, weaning, and vaccination. And then next is National Nutrition Survey by AQ and UNICEF, which include dietary intake, clinical and biochemical examination to assess the nutritional status. So the number four is qualitative data. Qualitative data include information on the health policies, health legislation, public attitude, program cost, procedure, and technologies. Um, health data. Health data include health system, health facilities, community information system, and disease surveillance. Data from the health facilities. A system of service-generated data derived from health facilities. Um, First is disease notification. Disease notification is a systematic reporting of specific disease to the public health authorities as required by law to enable timely surveillance, control, and prevention of outbreak. Purpose is early detection of outbreak, monitoring disease trend, planning, control, and prevention strategies to reduce morbidity and mortality, fulfilling national and international reporting obligations, for example, WHO. Uses and limitations are early warning and disease study, while limitations are underreporting, atypical cases, and limited coverage. Um, B is the disease register. A disease register is a systematic record of all cases of a specific disease within a defined population and time period maintained for surveillance, monitoring, treatment, follow-up, and research purposes. For example, diseases include stroke, TB, HIV/AIDS, diabetes, and congenital anomalies. Uses are study course of the disease and survival, valuable data on morbidity and treatment. Next is the hospital record. A hospital record is a systematic and permanent documentation of all the medical, administrative, and legal information related to patients' care in the hospital. It provides a complete history of diagnosis, treatment, and outcome for the each patient. Uses and limitations are uses information include information of health services and utilization, study patient demographic factors, relationship between disease. Limitations are only tip of iceberg include who take hospital care, admission policy may vary, provide only the numerator, not denominator to study the frequency of disease. Other health services records include primary health care, maternal and child health services center, polyclinics, private clinics, school health records. Uses are child growth parameter from MCHC. Limitations are represent only certain segment of population. So the next is the surveillance system. Surveillance system often the part of the disease control program. Some include some epidemic and endemic diseases, for example, TB, malaria. Uses of surveillance system is valuable data on morbidity of specific disease. Behavior surveillance focusing especially on the risk factors such as smoking, unsafe sex, malnutrition. It is a program of population survey. Population survey, population survey mostly household survey. Health information system should be population based. Three type of surveys are community diagnostic, community diagnostic include health status of population, disease factors investigation for etiology, and health service survey utilization post, for example, multiple indicator cluster survey, Pakistan demographic and health survey, Pakistan social and living standard measurement survey, National Health Survey of Pakistan. So there are four methods. Number one is the interview for subject issue, population based. Second is examination. Third is health facility record, and fourth is mailed questionnaire. Disadvantages of these surveys are unreliable morbidity data, expensive, not population based and uniform, non-responsive, need literacy. Health manpower state by PMC and mapping of health include environmental health data, identification and quantify agent. Limitation of this is data collection difficulties. Non-quantifiable information include policy, program, technology, and cost. Other routine stats include demographic, economics, sales of drugs, social security scheme, modeling and estimates and projection, and these are links to management information system. So the next is data needs and essential source of the different healthcare system. This include types of tools, level of healthcare system, and management decision. So the type of tool at the community level is CAP study, local household survey, and surveillance. Facilities include facility record, birth register, outpatient data, and surveillance. At the district level, service availability mapping, administrative data, and surveillance, while at the national level, vital gestation, census, national household survey, and modeling and estimate at the global level. Management decision is from operational to strategic. Uses of health information are measure the health status and quantify health problem for local, national, and international comparison of the health status, for planning, administration, and effective management, for assessing effectiveness and efficacy of the health, for assessing degree and attitude of satisfaction, and for research and training. So, major health information system operation in Pakistan include disease health warning system, health management information system, district health information system. Disease early warning system. It is used for rapid outbreak detection, sport emergency response, implemented in collaboration with WHO, weekly reported for health facilities, generate disease alert. It is used in 2005 for earthquake, 2008 to 2009 IDP crisis, and 2010 flood. Number second is health management information system. It developed early in 1990s, routine reporting from 1300 plus first level care facilities, initially paper based. report monthly, quarterly, and annually, include service utilization, immunization, maternal care, family planning, and drug availability. And number third is the district health information system, which is the revision of HMIS expand to all the districts, include district and Tehsil hospital, improved software, expanded report system, and still evolving. Advances in health information system. Pakistan's health information system has undergone significant transformation over the last decades, driven by the digital technologies, policy reform, and global health demands. Key advances include uh, digital transformation of data collection, national implementation of district health information system uh, continues to scale up across the provision and district. Digital reporting from peripheral health facility, Tehsil hospital, and district hospital has improved data timeliness and completeness. Improved dashboard with real-time reporting are accessible to the planner and policymaker. The impact of this are faster reporting cycle, reduce paper dependency, enhance geographic data visualization. Second is the first fully digital census with DJON enumeration. The 2023 Pakistan census was conducted using tablets, GIS, and DJON enumeration. GPS tagging household visit improved accuracy and reduced duplication. Data now provide refined denominator for health planning, particularly at district and sub-district level. Impact is better population estimate, improved service planning, strong foundation of HIS denominator data. Number third is integration of program information system. Vertical program database, for example, TB, HIV, malaria, EPI are being linked into a more uniformed health information ecosystem. Use of standard data format and interoperability framework allow integration of paper and electronic register. Impact is better cross-program analytics, more complete public health picture. Fourth is the electronic medical record, EMR adoption. Public and private hospitals are increasingly adopting EMR system. EMR facilities linkage between clinical care and health information system, enabling real-time diagnosis reporting, laboratory information integration, outcome tracking. So the impact of this is improved clinical documentation, better longitudinal patient data, enhanced quality of care. Number five is the disease early warning system and integrated surveillance. Disease early warning system continue to strengthen outbreak detection capability, especially for the epidemic prone diseases. Integration with district health information system and laboratory network enhanced responsiveness. Impact of this is faster outbreak alert, improved emergency preparedness. Sixth is the real-time dashboard and data visualization. In health information system dashboard now provide monthly indicator tracking, geographic heat map, interactive analytic for planning, dashboard support monitoring of immunization rate, maternal and child health indicator, disease trend, health workforce distribution. Impact of this is better evidence-based decision making, data accessibility at all the administrative level. Seven is the mobile health innovation, use of mobile app for data entry, reporting, and feedback loop. SMS and app-based reporting reduce delay, improve coverage. Impact enhanced community level data, improved reporting from remote areas. Linkage with National Population Register, NADRA Digital Population Registry support verification of demographic data, unique identifier linkage with the health record, improved tracking of birth and death. Impact are better record matching, more accurate population metrics. Next is the public-private data integration effort to bring the private sector data into the national health information system are underway, especially from the large private hospital and the diagnostic lab. More accurate health sector data reduce blind spot in the disease burden estimate. And number 10 is the use of AI and predictive analytics. Early application of machine learning and AI for predictive disease modeling, identification of risk cluster, health service demand, and forecasting. So the impact of this is decision support tool for planners and respiratory surveillance. While the challenges are, despite their advances, the health information system in Pakistan still faces gap in data quality and completeness, private sector underreporting, technical capacity limitation at the district level, and infrastructure availability across the region. Next is the MCQs. MCQs number 1 is, which statement best define a health information system? A system for collecting and storing a hospital patient file. B, a structure mechanism for processing health-related data. C, coordinating system for health planning and decision support. D, a computerized network for sharing laboratory result. E, a reporting tool used for disease notification only.
B.
Yes, B is the right option. MCQ number second, in a DJOR census method, individuals are counted basis on A, place where they are present on census night, B, area where they work during weekdays, C, location where they usually reside permanently, D, district where they are originally born, E, address mentioned in the identity card.
C.
Yes, C is the right option. MCQ number 3, after heavy flood in a district, several cases of acute white diarrhea are reported from the different health facilities. The district health officer want rapid detection of any outbreak. Which system should be activated first? A, routine hospital admission register review. B, district health information system reporting. C, disease early warning surveillance and mechanism. D, national population census verification system. E, household integrated economic survey module.
C.
C.
No, C is the right option. Disease early warning surveillance mechanism. MCQ number 4. During data analysis, has researcher noticed that census data include people based on their permanent residence, even if they were absent on the census day. Which census method used was used? A, de facto population enumeration approach. B, institutional head count documentation method. C, de jure population enumeration approach. D, sample based demographic estimation techniques. E, household listing verification strategy.
C.
C is the right option. MCQ number 5. A public health specialist want continuous compulsory record of birth and death with causes. Which system will provide the most appropriate data? A, periodic national household survey. B, vital station record mechanism. C, disease register at tertiary hospital. D, behavioral surveillance survey program. E, population census conducted every decade.
B.
Yes, B is the right option. MCQ number 6. A researcher calculates disease frequency using hospital admission data but cannot compute incidence properly because the denominator is missing. Which is the main limitation of this data source? A, incomplete environmental exposure detail. B, absence of risk factor documentation. C, lack of community population denominator. D, population quality diagnostic information. E, delay submission of facility reports.
C.
Yes, C is the right option. MCQ number 7 is, a survey team distribute printed questionnaire by post of to assess the smoking prevalence. Many forms are not returned and some are incomplete with limitation is most relative. A, high cost of biochemical validation. B, requirement of skilled interview. C, non-responsive and literacy dependence. D, limited hospital record accessibility. E, absence of sampling frame accuracy.
C.
E.
C is the right option, and non-responsive and literacy dependence. MCQ number 8, the provisional health department want weekly aggregate report from the primary health center to monitor service utilization and morbidity trend. Which system primarily serves this function? A, disease early warning system platform. District health information system network. C, population nutritional survey database. D, Pakistan demographic survey module. E, population census completion unit.
B.
B.
Yes, B is the right option. MCQ number 9. A policy maker wants data to on household size, saving, and expenditure pattern to correlate with the health services utilization. Which survey is most appropriate? A, multi-indicator cluster survey. B, household integrated economic survey. C, national health survey module. D, disease specific case register. E, behavior surveillance program.
B.
Yes, B is the right option. MCQ is number 10. A behavior surveillance survey report rising smoking prevalence, but the hospital lung disease admission remained stable. Which interpretation is the most appropriate? A, hospital data reflect population expenditure, exposure. B, risk factor, migrable and morbidity. Smoking prevalence is overestimated. E, lung disease history incomprehensive. E, census denominator is accurately projected.
B.
B is the right option. So this is the answer key. This is the YouTube channel where the recording of this presentation will be uploaded. And thank you.
Thank you very much. Would you please stop recording?